alarming report out today on mentally ill women prisoners injuring themselves. This is the report right here behind bars. Correctional Investigator Howard Sapers studied 8 of the most chronic high-risk women offenders for 30 months, and he's released the findings in this new report. It's called Risky Business. Let me show you some of the findings in this thing. The report found that the total number of self-injury incidents in the federal penitentiaries has tripled since 2007. That's after the high-profile death of teen prisoner Ashley Smith. Those incidents include cutting, headbanging, and self-strangulation. 7 of the 8 high-risk women studied were Aboriginal. Aboriginal women account for 70% of self-harm incidents of female offenders, and all 8 of these women had been previously diagnosed with significant mental disorders. So why have the incidents of self-harm risen so dramatically, even after the death of Ashley Smith 6 years ago? Testimony on her today from the prison warden. Even after that case flagged some of those problems in the correctional system. Are mentally ill inmates being treated as security risks instead of getting the proper treatment? Joining me now, the Correctional Investigator of Canada, Howard Sapers. Mr. Sapers, good to have you back on the program. You and I have talked a lot about self-harm issues in prison for a long time. Can you tell us the most shocking findings in this report?
Well, really for me, it's that we've got such a small group of, in this case, women who are so often injuring themselves, and sometimes those injuries ending in tragic circumstances. It is a deep concern of mine that we get these people into appropriate treatment. At some point, a prison just doesn't have the capacity to offer the kind of complex and acute care that these individuals require.
Can you give us an idea of some of the findings as I look at them? And I'd urge people to read some of these findings. It's quite extraordinary. Give us an idea of what you found here in this study.
Well, the context is that in the last 5 years, the number of self-harm incidents in federal penitentiaries has tripled. So then we looked at just last year, and we saw last year there were over 900 incidents, and within those 900 incidents, there were 37 women who were responsible for a third of those 900. So 37 women, 300 incidents of self-harm. That led us to look at the daily situation reports that we get from CSC, and we identified the 8 most chronically self-harming women. This is going back a couple of years now when we first decided to commission this investigation. We followed those women for 30 months, and we looked at how the CSC, the Correctional Service of Canada, was responding to their chronic and serious self-harm. And what we found is that overwhelmingly the response was not a health care or a treatment response, it was a security response. Very similar to what we found when we investigated the circumstances around the death of Ashley Smith.
Right, and what a day to talk about it as of course, Cindy Berry, who was the warden at the Grand Valley Prison for Women, testified today about how Ashley Smith was treated. And then you look at the findings in this report, and it says prisons are ill-equipped to safely and appropriately manage the complex mental health needs of federally sentenced women who are chronically and seriously self-injure. I mean, it's uncanny that this is coming out. That's a critical finding.
Well, it is a critical finding, but let's remember that the Correctional Service of Canada does have the capacity to deal with a wide range of mental health issues. They have 5 regional psychiatric hospitals. They have a specialized unit for women in one of those hospitals. They have teams of psychologists and psychiatric nurses. They can deal with some mental health. We're talking about a very, very small population of the most acutely mentally ill and those who most seriously self-harm. It's a very small number. They need specialized care.
But you say there's a misunderstanding of the difference between segregation and clinical seclusion. There's a discrepancy between staff training and the response to self-injury. Security staff are typically the first responders. That may not be the way. There's gaps in the availability of treatment options for complex cases. I mean, the list goes on and on.
Yeah. And you see, the problem is that these individuals who are very ill and who chronically self-harm require a lot of attention. They take a lot of resources. And often the first responders are security staff. They're correctional officers. And these correctional officers may have some training in first aid. They may have some training in mental health and dealing with symptoms of mental illness, but they're not healthcare professionals. And prisons aren't hospitals. And so these incidents of self-harm, they can happen any day of the week, any time of day. The first responders, 24/7, are security staff. And this just creates this escalating series of behaviors where there's an incident, a security response, an escalation in the incident, an escalation in the response, and it's not working.
I mean, if you look at Ashley Smith in the testimony today, that Grand Valley developed, quote, a management plan for Smith that involved small rewards if she behaved well, but if she behaved poorly, they would literally withdraw warmth and engage very little with her.
Yeah.
I mean, would that be part of your not managing someone properly?
Yeah. One of the recommendations that we make today is that every one of these individuals requires a comprehensive, current clinical treatment plan. And for those who are beyond the capacity of CSC to treat, we're saying part of that treatment plan has to be the transfer to a hospital. If these people were physically ill, if they were dealing with complex cardiac problems and they needed heart surgery, that surgery wouldn't be performed in the health unit within a federal penitentiary. They'd be moved to a hospital. What we're saying is the same thing has to apply to complex and acute mental illness.
Let's go over what you recommend here, and I'll get to the government response. You say things, as you say, move them to a hospital, don't take care of them, but you have things, under no circumstance should non-consenting or uncertified offenders in a penal restraint system be subjected to forced medical injections. Is that happening?
Yes, yes. We're finding people who are put into restraints as part of a use of force intervention, and we've seen people being given involuntary medications who aren't certified under provincial or territorial mental health legislation. And
you say restraint equipment should not be used with self-injurious offenders, and that's being used.
It's also contrary to policy, but yet we're seeing the creation of something called consensual use of restraints, which you have to get your head around that.
What does it mean?
It means that somebody knows that their behavior may deteriorate. So they agree, and I say that advisedly, they agree beforehand to be put into restraints. Now, if this was in a hospital setting, you would be put into restraints for a very, very short period of time. You'd be clinically supervised while you were in restraints, and then you'd be out of the restraints. In a prison, we have records of women who have been kept largely in restraints for days and days and days on end.
Restraints mean they're essentially tied up, or
there's different kind of restraints. There's being strapped to a table. There's 3 and 4, 5 and 7 point restraints. There's specialized chairs that are restraining chairs.
For days.
But these restraints should not be used punitively. They're also not clinical. They need to be used under very specialized circumstances, and we say medically supervised.
All right, given what you found here in this risky business report, here's what the Public Safety Minister, Stephen Blaney, sent out this statement in response to your report. Quote, "We thank the Ombudsman for his report, which encourages us to continue to implement our mental health strategy for inmates. We believe that prisons are not the appropriate place to treat those with serious mental illness. Our government will continue to work with the provinces and territories to ensure that our streets and communities are kept safe." What's your reaction to that?
Well, frankly, I'm very encouraged. If the minister sees this as assisting in the efforts for the Correctional Service of Canada to actually realize that they have a capacity, a challenge in this regard, and deal more aggressively with moving these small numbers of offenders into forensic hospitals, then I'm encouraged.
What do you think their mental health strategy for inmates is sufficient?
Well, the mental health strategy per se,
quoting them.
Yes, the mental health strategy per se is a good strategy. We've been on record supporting it. The problem is they're not implementing it the way it was designed.
Okay, so they say we're continuing to implement it. So what's the problem there?
Well, hurry up. I mean, that's really what the issue is. There's still no funding for intermediate care for men. There's still no specialized resource for women who chronically self-injure. The strategy is not a bad strategy. The devil, of course, is in the details.
So when they say we'll continue to implement our mental health strategy, your question is, are you really implementing it?
Well, they need the resources. They need the direction. They need to make it a priority.
All right. On the day that Cindy Berry, the warden for Grand Valley Prison for Women, testifies in the death of Ashley Smith 6 years ago, the Ombudsman puts out risky business as an investigation of the treatment and management of chronic self-injury among federally sentenced women. Howard Sapers, thanks for being here.
Thank you.